Who knows the word quadrophenia? You're all showing your age because it was the Who's second rock opera. It's called Quadrophenia, but it was with an O, not an A. It was quadrophenia, but I've adopted that for this. So thanks. I'm meant to make the bridge now from purely clinical towards the research because this is a research symposium, and from here on in, it's going to be full-on research. So that's my task. So what does it bring to clinical scanning? As Paul's pointed out a number of these points, but I think the bottom line for us is firstly the flexibility. I thought we were really going to be locked into a very tight schedule. You know, all those boxes that Paul showed you on the roster, I thought it was going to be a nightmare. In fact, it's very relaxed scanning. There's often time between patients. There's often time when there's no one on the scan. You think, shouldn't there be someone there? And in fact, with a 5-minute scan, you can end up waiting and saying, oh, it's too early, we can't put the patient on the bed just yet. So it's really been surprising, and the flexibility to do the same day dual scanning and things like that. And you can play with the doses. You can cut the dose of the early scan. You can increase the dose of the later scan. So there's no crosstalk. You exploit that short half-life of gallium-68 of 68 minutes. Wait an hour or two. When you inject your FDG and then scan an hour later, you've virtually got no gallium left in the patient. So that really works well. And there's a lot of financial toxicity around cancer patients, especially those that have a long life ahead of them with their chronic disease. I think the other thing that Paul and I are realising is that there's a possibility to maybe even alter how we do our investigations. We've certainly been looking at some early uptake of peptide imaging, gallium-68, PSMA in particular, and wondering whether we need the 60-minute image. Now, if you can get everything out of the first 10 minutes because of the high sensitivity and the high contrast that you get in those sorts of images, that's could change practice dramatically, because now you're not got uptake rooms full of patients sitting there for 50 minutes waiting to get on the scanner. You actually could just walk someone from the waiting room in, pop them on the bed, inject them, and 10 minutes later say goodbye to them. So these are the sorts of things that once you've got a tool like this in your hands, I think you get to think about it. Could we do things differently? And I think this scanner will have some contribution to that. The image I'm showing is actually patient number 1 on the scanner, and that was an 8-minute scan at the time that we were doing. So 8 minutes of FDG PET. What does it bring to clinical scanning? Faster scans, less dose, improved quality. You can delay imaging if you want to try and improve the contrast and clear from the body, as Simon's pointed out earlier. Cost savings that Paul and the accountants are very interested in, of course. The same-day imaging, whole-body parametric imaging, we heard from Simon. And I think in particular new clinical areas, I think one that is emerging for us is looking at vascular inflammation at the whole body level, not just perhaps in the cranial arteries or in the cardiac area. So I think we're going to see new things coming up for that. But this, again, a comparison. I'll pull this one out because I think this was actually one that flashed up in front of me during an MDT clinical meeting. This is the same patient. She's got lung cancer. When we scanned her on the older scanner, you can see on the left there, she was in remission. And then she came back 18 months later, and unfortunately, she's got some progression, as you can see on the right side of her chest there. But apart from that, she hasn't changed her weight very much. We've taken the dose from 250 megabecs roughly down to 150, and we've decreased the scan time from 20 minutes to 5 minutes. I think even on this screen, you'll probably all appreciate the much better definition and image quality that we've got. Again, as Paul pointed out, look at the uniformity in the liver there. And this is a 5-minute scan. This is now what we expect on every scan, and that's the standard that we have now. So it's really very impressive and has caused a number of concerns, I think, for our physicians to say whether something is true progression or not in small lesions that may not have been visualised before. And we still have that problem to this day with scans that are done outside of this institution, of course, that they're coming back to us for a scan. You've heard that we had a long gestation period for this project, and one of the things that did let us do was work with some of the university people, Peter Kench in particular, and Jackie Chen, who did this work, and we were able to do patient samples of a survey of having the scan done, and we had 3 months of sampling beforehand, and then we've sampled patients as they come back after on the new scanner. And look at some of the results here. How long we're in the department, much less on the Quadra in orange compared to the older system, the Biograph. The comment about the PET scan took too long. No, we don't. No one's really agreeing with that anymore. Did you feel anxious? Less so with the Quadra. And did you feel claustrophobic? As Paul pointed out, we've actually measured this now. So I think this is a nice piece of work that Jackie's done. Because we had that long delay, we actually had the time to think through this, get ethics, write the survey, and actually run it. So we've got some nice qualitative data about that as well. What does the scanner bring to clinical translation, trying to move into that area, which I think is very much where we are operating at the hospital end? Well, there's a great improvement in clinical trials. So the images on the bottom are copper-64 images of neuroendocrine, a patient with meningiomas. So you can see focal uptake in the top of the skull there. They are lesions sitting just outside the brain in the skull, and they take up the dotatate or dotaoctreotate. This is copper-64 imaging with Clarity. Eve will be very familiar with this. And we did these scans out to 24 hours with a trace of copper-64, which has a 12.7-hour half-life. We can go much longer now, I think, when we get the with the same sort of studies, we could go out to 48 hours or so, and so get more biodistribution and change over time. And particularly in this tracer, we were a bit surprised that the washout rate from the meningiomas seemed to be quite high. So we can improve that. We can extend our imaging over more days at higher quality for that biodistribution. We're going to get whole body parametric imaging, as we've seen, and for research. And I think that's going to be really important. And we're going to get continuous whole body imaging. We don't need to, as Paul said, when you take 8 images of the body, you stop imaging at the other areas as you move along. And so you get episodic sampling. With this, we'll get continuous sampling. And I think also important for phase 0 and 1 trials, we'll be able to use less radiopharmaceuticals. Simon alluded to the radiation dose from the zirconium-89. We can actually now get down to very small doses of less than 40 and less than maybe even 20 megabecquerels, which brings that back into a much more favourable position. Here's an example of a study that Andrew Scott kindly allowed me to show to you. This is a current trial called the iFirst trial, looking at patients with radioiodine refractory thyroid cancer with metastatic disease, and so not able to be treated initially with radioiodine. The patient on the left, these are 2 different patients. The patient on the left is one who's had a 40 megabecquerel drink of iodine 124. This is the 24-hour image and a 40-minute scan on the old scanner. That's the quality we used to get. And now on the right is with the new scanner, different patient. This patient actually has now got radioiodine uptake. You can see right throughout the chest there. Same dose, same uptake period, and a 12-minute scan. And I think from a research point of view, this is going to be tremendously important and useful to have that extra sensitivity, extra spatial resolution on the new devices on the digital scanner, leading to much better overall image quality. I mentioned continuous sampling. This is some nice work done by our colleagues at Prince of Wales and the Centennial Institute, looking at an agent which looks at apoptotic cell death. And they have sampled here every couple of minutes to get a whole body study. You can see the FDG scan with the uptake in the upper neck in the FDG PET on the left, and then images roughly every 7 or 8 minutes over a couple of hours, and giving you those discrete points you can see in the biodistribution graphs. But with this scanner, of course, we don't need to do it episodically like this. We can do it continuously. These could be done at a couple of seconds per image. And so continuous 1-minute sampling over 60 minutes is already something we've been doing with our FDG scans. So looking at the bigger picture, what does this translational device bring to us at the hospital, to the University of Sydney and to Australia? I think the first thing is it's been the opportunity to have access to a shared device with a shared risk. I don't think either organisation, the hospital or the university, could have really taken this on and made it work on its own. And so I think this shared model is a very interesting one, and we are determined to make it work. And so far, it's been, from the clinical side, we've been able to slip into our mode, meet our objectives, get the number of patients done that we need to do in a day, and now ready for the university to come online as well. We're able to offer our patients state-of-the-art functional imaging at very high sensitivity. Researchers and startups have access to the best technology available. This is state-of-the-art every day of the working week, every afternoon. I think we're making this attractive to international pharma for a number of reasons. In Australia, we have a favourable regulatory environment at the moment and high quality resources. By that I mean the imaging equipment, as well as the staff to run this. And I think we've got a really high throughput clinical environment, and we've been flogging the camera for 3 months. You can see Paul's figure, 1,500 scans in a couple of months. So our staff very rapidly became very capable of using the system, and to the point where now we can get things done very quickly. And we've honed our skills there to work really rapidly. And so I think those skills will naturally lead into the research studies, where we'll be very flexible and adaptable and able to suit the university and the researchers' needs, and we'll be able to get the maximum out of that. So I think this dual role is actually very important. And so I think it'll be a useful model for others to look at. And finally, I think we just got to also say a big thanks to NIF for making this happen. It wouldn't have happened without their input and support, and to all those that have contributed. So thank you very much.